Right out, just checking the message. That's all cool. So we'll just open with our karakia, and then we'll get into the proceedings. Kia hora te marino, kia whakapapa panamu te moana. He huarahi mā tātou e tarangi nei. Araha atu, araha mai, tātou e tātou, I ngā wā katoa, hui e taiheki e. So first observation is to record an apology from Norman. So that will just be placed on the record. Norman messaged us last night to advise he was unable to attend today's board meeting. We'll just go through the administrative stuff first, just to check in. I'm not aware of any late items. We got the registration of interest that we all know to update, and we can fire that through to Margaret as appropriate. We've got the board minutes from the 14th of December, and it'll be just useful to move receipt of those minutes. If there's a mover for that, moved by Vaughan, seconded by Muriel. Are there any matters arising from those minutes of the 14th of December? No, everybody's comfortable. So I'll put that in favour. Please say aye. Against, it's carried. I think what we'll do is the old raise hand thing rather than going on and off mute. So we'll just do it that way. Okay, thank you. We've got a verbal report now from the board chair. So the verbal report is modest, but it's particularly focused. We're all aware that it's less than 20 weeks before this governance board concludes its role as we transition into the new model. In less than 20 weeks, there is an enormous amount of activity that's going to occur, and I'm going to use the words from Mataroa, which describe the next 6 months, which is a confused landscape. Now that's fair language. That's not a criticism. It's the reality of a transition into the new entity, where many of us are wondering what this might look like, how it might work, and how does actually transition occur. And there's multiple levels of activity at the moment. We know the transition unit's been in and done its work. We know there's the establishment of Health New Zealand and the Māori Health Authority, and we know there's now transitioning of staff into those roles. Those entities are taking shape and getting up to speed into their new roles. While all that's occurring, we as a board are responsible for continuing to deliver the services that communities expect. We're requested by the Minister to ensure that we control our expenditure, our budgets. They're not looking for deficits beyond what we've already been approved, and to deliver those contractual activities in terms of infrastructure that we've got on our plate at the moment. The point that I need to make as a chair in support of our board is to our employees, to acknowledge the strain that this creates as a transition occurs. The message is that I want to assure everybody that we are, as governors, acutely aware that executive leadership teams are looking for direction, and those executive leadership teams are seeking direction from those that report to them, and so on through the system. So for me at the moment, that's my #1 priority. How do we ensure that Health New Zealand and the Māori Health Authority, Health New Zealand specifically at the moment, how do they articulate back through the system to provide confidence to employees and surety of understanding around what's occurring? So I don't want to go anything beyond that. We could talk about COVID and Omicron and everything else that's going on at the moment, but I just wanted to prioritize into this one point, which I think is significant. And as I've said to the board, chairs and CEs are meeting in Wellington tomorrow and Thursday, and that's going to be an opportunity to get, I hope, significantly more clarity to bring back. And it's certainly for me to engage in discussions to articulate my particular concerns around that continuity. So that's as much as I'd like to present in terms of a verbal chair's update. So if we're, and I don't imagine there's any questions, it's just an update, so we'll leave it at that and we'll move through to the next item on the agenda, which is the FRAC minutes from the 1st of February to move that they are true and correct record. So that's moved by Oriana and seconded by Vaughan. Is there any discussion on those FRAC minutes from anybody? Karen?
Thanks, Brendan. Just a couple of questions I had looking at the minutes. Page 6 at the top of there, it talks about the sick leave, and it says that the majority of the sick leave over the quarter had been stress related. And I'm just wondering how that's determined and how that's monitored, and also interested to hear what the support programs are that are put in place that are described there.
Hold on. So that's going a bit beyond what about the approval of the minutes. It's kind of like, you know, seeking some extra points of clarity.
Oh, so it's matters arising.
Yeah. So just tell me what the item is again. It's at the top of page 6. Yes.
So it's under health and safety and wellbeing, 6.3.
Thank you. Yep.
So it's the top paragraph that I'm looking at on page 6.
Okay. I'm imagining that Kaya is the appropriate person to give us a response in that space. So maybe it can be noted for Kaya to provide an acknowledgement there. I can't do anything. Is that all right?
Yeah, and just one other question on the same page,
yep.
Down into the 4th paragraph, it talks about the 2 unvaccinated staff.
Yes.
Just wondered, it said one was a senior clinician with a longer notice period than that was being worked through. Just wanting to confirm that staff member isn't currently working.
Yes, they are working, but they're not working in the physical hospital setting.
Okay.
Do they have contact with patients or community?
No, because that would not be consistent with the requirements of the mandate.
That's great to hear. Thank you very much for that.
Okay, so there's no other points in matters arising, and we've had a mover and a seconder. So I'll put that in favour. Please say aye. Against. Aye. Carried. Thank you. We've got next on our agenda is a verbal update from Mana Whenua Holder Chair.
Kia ora, Brendan. And so what we decided was that we wouldn't have written reports anymore, and that was due to the timing of the meetings. Mana Whenua Holder had their meeting on the 28th of January, and that's not enough time to get a formal paper into the board. So we decided that it would be verbal. As everyone knows, we cancelled this afternoon's board to board due to, as it turns out to be, great timing in terms of where not only the DHB but also iwi Māori providership is at in terms of the COVID response that we're in the middle of at the moment. There are a couple of things I'd like to feed back to the board. One is that we've appointed a project manager transition to support Mana Whenua Holder into the new environment. Trevor Shaler has come on board with Mana Whenua Holder for 6 months to lead that transition piece. The priorities there is the establishment of the new board, and that's well underway. The other part of that is establishing a legal entity for Mana Whenua Holder. And so we're working through, he's working through that at the moment. What we would like to do, our last board to board is in May, and before that, we'd like to put together a retrospective really over the last 21 years since the establishment of DHBs, and acknowledge a number of individuals that started on the journey. We worked out yesterday that of the 10 or so that were at the formation of Mana Whenua Holder, there is only actually 2 left on this earth. All the others have passed away, and many of you on this Zoom will know a number of them that are no longer with us. So we'd like to do that and acknowledge those that have been part of the journey along the way. In terms of collecting some history as we move out of the DHB environment. So that's a project that we have got, and of course it's going to be a joint one with the DHB. The other matter I want to touch on is the development of the prototype that is due with the ministry on Friday, and that is progressing well. And it's a collective effort between the DHB, Mana Whenua Hauora, Think Hauora, with Te Tihi holding the pen on that project. So that's really the things that I wanted to highlight. And and the last thing I want to say is that iwi met yesterday and have decided that there will be 7 iwi groupings on the new board, and I can let you know about that as we get in a bit closer, but it will be the 4 that currently make up Mana Whenua Hauora, and that's Kahunu, Rangitane o Tamaki Nui Arua, Rangitane o Manawatu, Moaupoko, and Ngāti Raukawa. I don't think I've missed Kahunu, I think I've said. So that's a pretty exciting space to be in. The additions are Te Ruru, which is a collective in the northern part of the DHB Rohe, and the other one is Ngāti Kaupata. So I shall keep people informed, but it's quite an exciting development. Any questions or comments?
Thank you, Audrey.
Thank you.
Okay, so that's a pretty good update, and I think you are right. The decision that we collectively agreed on last when we decided to pull the pin today turned out to be accurate. Right, I think we can move on. So the next item on our order paper is the COVID planning update. And Deb, you're leading that, and it looks like somebody's.
So Brendan, if you'll bear with us, so I'm just going to lead off and talk to the first couple of slides, and Calvin and Deb will join in, and I see we have our colleagues at the PHO welcome to also join in with this conversation.
Okay.
I'm hoping that we can move pretty quickly through the slide pack, but given the move to phase 2 at midnight tonight, it is indeed quite timely that we talk through where we're at in terms of our COVID resilience planning work and what the shift to phase 2 means for us. Before I do that, it might be helpful if we could just perhaps have a quick update on where we're at in terms of our vaccination reports. We are making steady progress, and it's no news to everybody in this meeting that our biggest defence against Omicron is the level of boosting that we can achieve in our community. So in terms of our general vaccination status, so we have achieved in our rohi 97% of our population being partially vaccinated and 95% fully vaccinated. So that's good to know. We have reached the milestone of 90% of Māori now having had their second dose. There still are some individuals that would need to have that second dose for us to say that we're really confident that we've achieved that, but on a statistical basis, that's what's being reported. And for Pacifica, we're now at 101% and 98%, and that tells you probably what we already knew, that there is some underestimation across all population groupings, including Pacifica in these numbers. Then if we go to an area where it would be fair to say we'd like to get our pedal to the metal on this one, to use a technical term. So we've currently got 40% of our 5 to 11s who are vaccinated, and we are seeing, despite our best efforts, an equity gap emerging in there. So 26% of Māori, and then for Pacifica, 31%. So we're working through that as we speak. In terms of our boosters, you know, we pleasingly have achieved 63% of our population who are eligible having received that booster. We've got significant efforts to enable our populations to receive their vaccinations, and there is certainly what I call pressure on our workforce. We have this week opened the plaza pop-up again, having worked through some challenges that there were in that environment, and we'll be moving into a more permanent environment within the plaza in the March period. So that's just a bit of a run through there. If we move now into the actual coordinated response for our resilience planning for COVID, if we we'll just move on to our next first slide. I just wanted to remind you of the operating framework that you will have seen before. So we've worked on an approach where we have pillars and pillar leads, and that's continuing. So I'm not going to talk about that. Okay. And then we have our enablers. These are critical supporting elements of our response that underpin the broader clinical response. Okay. This is our, again, you will have seen this, this is our approach to our localities through our clinical locality hub. So I'm going to hand over to Deb, who's going to, I think it's, or is it, well, Deb, I'll let you, I can't remember whether it's you or Kelvin, I can't remember what the next slide is.
Sure, thanks, Kath. Kia ora koutou. We'll just pop onto the next slide, and we're just going to talk a little bit about what we understand is going to be the impact of COVID, and then I'll talk through some of the process of moving to phase 2. Thanks, Kelvin.
Yeah, so the ministry put out some supporting a framework with which we could do a little bit of modelling, and you can see on the left 2 columns reflect pretty well where we are or where we'll be in the next 7 to 10 days as far as the boosters are concerned. But if we do reach that figure of 70% boosters, likely to be heading towards 23% total cases within MidCentral, and with the peak daily cases potentially getting up to just over 700, around about 740. Obviously, with that, a small percentage, just well under 1%, would result in some form of hospitalization, hospital admission. And out of that, and there's an even smaller peak of those that would actually might be heading into ICU, and that is actually the core benefit that's coming because of people getting their boosters. The booster actually prevents severe infection and prevents severe hospitalization. So those people who end up in ICU, a greater proportion of those are those that have not had any vaccination whatsoever. And you can see, just shifting to the 2 right columns, you know, where we actually want to be heading to, the importance of continuing booster, getting the vaccinations out, and adhering to some of the ministry's guidelines, the level 3 with which we're in at the moment, adhering to social distancing, mask wearing, and those sort of things. All of that collectively adds into lower transmission rates. Next slide. I'll actually hand over to the folk at the primary healthcare here. You can just elaborate this in a little bit more detail, but effectively they have done some work looking at some of the risks and risk stratification. We know that people who get COVID more likely those that have got comorbidities and risk issues. So Paul, colleagues in PHO, do you want to make comments about this in the next slide?
Thanks very much, Kelvin. Marina. This risk stratification tool allows the general practice teams to, I guess, divide people up into those who are at higher risk of, serious outcomes from COVID infection versus those who are likely to have a mild or very moderate illness. And this is based on people's age, their ethnicity, but also their long-term conditions. You can see from the pyramid on the left-hand side that we class like 6% of the population at high risk based on that demographic data we have. The vast majority of people we consider to be at low risk. You'll be aware that with the Omicron being generally a mild illness for the majority of people, we expect that most of the people in that low risk group to be self-managing. This will be a sort of a mild to moderate viral illness, which they will manage themselves at home using the self-help resources which the ministry are still in the process of developing. We expect actually the vast majority of those people in high risk will also manage very well at home. But there will be a proportion of that group who will require some extra support and who may well end up in hospital as a result of their illness. And that's particularly people who've got severe respiratory or sort of cardiac conditions where viral illnesses can be quite serious for them.
Right, next slide, Kelsey, thanks.
So this slide sort of again, I guess, breaks down that risk stratification, but it uses those sort of COVID specific factors, which are vaccination status, age, ethnicity, and comorbidity, to try and give a bit more sort of detail about the numbers who may be involved, going from the blue group who are at the lowest risk up to those in the red who are at the highest risk. And I guess it just gives us some idea of the likely sort of distribution across our district and where the sort of pressure points may occur. I guess that does depend on how COVID sort of rolls out across our district. And as Kelvin has said, we've got good booster rates which are increasing. We've got a lot of other public health measures which will hopefully help to flatten that curve as well.
Great. So we have just on 10,000 people in this red category, and a good majority of those who carry those risk factors are the ones that are likely, can I just stress, likely to be admitted into hospital. And so part of the primary healthcare work and the collective coordinating work is to strengthen and to support these people in the communities to try and keep them out of hospital and to obviously provide the wraparound services. Next slide, Kelsey. Great. I'll hand back over to you, Deb.
Yeah, thanks, Calvin. Thanks, Paul. Some really good work. So we do know kind of what's facing us in terms of enrolled population. Just acknowledging that we do also have plans around how we can be assessing those that aren't enrolled. So we're in phase 1 now. I won't stay on the slide for long because this is the current focus, which changes at 11:59 tonight, as we all know, where there's still a strong focus on PCR testing, a very public health based approach around every case that's discovered, active management of close contacts, isolation periods, primary care involvement where necessary, and we've got limited alternative accommodation options available, and we're utilising some of those at the moment, and a pretty well joined up welfare response between our CSIQ, so supported isolation and quarantine coordination centrally, and our very important iwi and MSD partners. And as we're all aware, we're moving to phase 2 tonight. Thanks, Kelsey. So this slide's just a quick overview of what actually phase 2 looks like for us, and just trying to distill the multiple areas of information we've probably all been bombarded with. But the key areas here is the testing phase will change somewhat in terms of the focus for PCR testing on symptomatic and close contacts only. So that will require some discipline and support for us in terms of responding to testing inquiries, moving to using rapid antigen testing as a adjunct strategy around confirming positive, and then to a PCR test. There'll be more asymptomatic surveillance, and very importantly, we'll be looking at the test for return for asymptomatic healthcare and critical workforce. So we are thinking about, as Omicron moves into the community, how we can continue to maintain critical services. The face of case investigation and contact tracing, the public health unit key role going forward really will be focusing on high priority cases and exposure events, and particularly around priority populations that have impact on the more vulnerable people. Symptomatic contacts will become probable, so that's a change to the testing. Cases will be receiving notification via text and a phone call necessary for when necessary for an interview. And it's really important. This is the phase where we start where self-notification and then self-check-in around your investigation commences. A change to the isolation and quarantine, back to 10 days for cases and 7 days for contacts. Obviously both with the caveat of 72 hours symptom free before you can come out of isolation. And we think about some of the impact that will have on whānau and the bubble as well. Continue with alternative accommodation where available. So I said the care in the community now is transitioning to self-service in terms of getting that notification and then entering into the online tool. We'll talk a little bit more about what the tactics are for those that are unable to do that, or we're worried that we aren't actually engaging in that. Clinical care by primary care teams, Paul's just given a good overview of kind of where we see that's where the risks lie. I guess if we turn that around to the positive, there's a good percentage of our population that will manage well without too much primary care oversight or intervention, and there are a lot of online and other supports available. And a key part here is really making sure that we have good all of government engagement to ensure there's multiple entry points for people that do need to access any sort of care in the community. Mask protocols are changing somewhat, more affecting our critical and health line workers, our healthcare workers. And just the bottom line is just really stressing again the things we can continue to do for our protection collectively around the booster, the vaccination, the masking, scanning and passing, using the vaccine pass, the hygiene and physical distancing, and that key message about staying home if you're unwell. Thanks, Kelsey. Look, as we move into phase 2, and we don't know how long the trajectory will be between phase 2 and phase 3, I think the key part of this slide really is that, again, the testing strategy will become even more confined and prioritise the PCR testing around priority populations, an escalation in the use of the rapid antigen testing, either self-administered or supported administered, but a continuation of the making sure that those people most at need of any level of support or wraparound services, that we can identify them and support them in the community. Thanks, Kelsey. So this is a modelling slide as an example of how we can translate all of the work that we've built up over the months and have presented previously to the board in terms of the strands of care around welfare, supported community isolation and clinical care. So if we start on the left-hand side as you're looking at this at the screen, this is an example of how we can identify quite early up on that. Step 1, we're looking at initially making sure people are safely isolating at home and identifying their support needs they may need that are non-health related. Very quickly alongside that, aligning for every case that's diagnosed as positive, is understanding at our central level for Aotearoa, who of those people are actually sitting in that high risk strategy, and starting to think about what the trajectory is for the engagement with those people. GP enrolment, whether they're enrolled or not, we have a strategy to support our whānau across the rohi from that first initial assessment onwards. And the initial assessment there, this is an example from Auckland. It's not exhaustive in terms of some of the tactics we'll be using about making sure that we are supporting people in their whānau and thinking about what that proactive in-day care looks like, so that when we get to that after hours space, that people are feeling well supported and also know where they need to go for support. Kelvin, did you just want to jump in around the clinical acuity part?
Yeah, so just for your awareness, a clinical tool, a clinical assessment tool has been developed. Specifically, this was developed for Delta and is now being revamped for Omicron. But essentially, there's 6 different categories that come from that assessment, right up to those you'll see in the orange on the far right-hand side requiring hospitalisation, and that's usually based on on respiratory status. So when you see on the acuity level 5s and 6, that's actually referring to a COVID clinical assessment that's happening and supported within the community, primarily at the by general practice and iwi health teams with that. Thanks, Deb.
Thanks, Calvin. And just to the last slide for Kev to wrap up. You're muted, Kev.
Always one. Every meeting. There are some continued areas of focus that we need to aim to have resolved this week if possible. So we're still continuing to resolve the issues around how we support primary care and individuals in the out of hour period. And that includes how our specialist services may support primary care across actually the in-hours and out-of-hours environment. We're still, we've had our hub stood up. So the hub is a critical part of how we manage the clinical and welfare needs of people in our community across the full continuum. And we've been had the opportunity with the cases that we've had to date just to see how that's working. We have a good relationship into the MSD and of course with our other partners who we, goes without saying that we work closely alongside iwi, and Wayne sits in at the daily hub meetings on behalf of iwi, Wayne Blissett. So that's working well. There are still some questions around SIQ. That's changing sort of centrally in terms of the move of that to MB and the use of orbit travel around booking that. But in the meantime, we're maintaining our local SIQ arrangements as we go forward. We've already talked about clinical acuity assessment prioritization, so further work. The flowchart that you were just looking at is being further developed as a national framework with some input. Would be fair to say from an equity perspective, from a Te Tiriti perspective, there was a view that it wasn't sufficient, and so that should be being worked on as we speak. And I've sort of talked about again, I think it goes back to the tools that we've seen. We need to understand the needs of individuals. We need to monitor them and be ready for them across the broader range of services in our community. And of course, understanding those individuals, which you will have seen in the models, the risk stratification, the clinical acuity tool, those individuals who are at higher risk and who are likely to end up needing hospitalisation. Of course, we're moving into an environment where we're likely to see people in our setting, our hospital setting, for a range of reasons who may in fact at that time be diagnosed with COVID. That's certainly the overseas experience, so we will expect to see that as well. And indeed in the weekend we did have an event where we had an individual with COVID in our maternity area visiting. That was good because it gave us a chance to test out, well, the actual thing wasn't good, but what was good was our system wasn't found wanting. We had been screening and we had a record of everybody who had been in that environment, including that individual. And of course, everybody was in PPE, so low risk exposure. So I might just stop there. The team is on still here, happy to answer any questions that you might have, but thought it was timely just to give a sense of the work that remains in progress. We're looking at modelling. In the end, I guess, I think someone who was being interviewed, I think it was Professor Skegg this morning on Morning Report, said it's time to buckle our seatbelts and get ready for the ride. I think that's how we're all feeling, and we will respond as we always do when we're dealing with this. There's a fair amount of apprehension, but I'm confident the team across the broader rohi, will be ready. But we'll have to make some quick decisions in some areas where perhaps we're not quite ready.
Well done, Kath and team for that significant, detailed overview of what we've got in front of us. Whoever prepared that deserves a medal. Very, very, very clear. And so thank you. I'm sure there'll be points of clarity that board members will want to raise. So just give us a sense. So Heather.
Thank you, Kath and Debbie and team. Oh, and Kelvin. That was really interesting. Look, I heard on radio last night, and I'm not sure who the commentator was, speculating that the peak will last between 4 to 6 weeks when we hit a peak of diagnoses. Is that what we're anticipating, that we'll have a burst through this and come out the other side as Omicron subsides?
Might get Kelvin to answer that one.
Yeah, thanks, Heather. That would actually be the worst case scenario. And I would say that it would actually be brutal for health services if that were to happen. If, however, we continue to increase our booster doses and get them close to, say, to the 90%, what that means is that instead of having a 6 to 2 month period of COVID, it would be spread out over 3 to 4 months. And that would be a lot manageable. It would also mean that instead of having 23,000 cases, we might only have 13,000 cases. So the core message is keep pumping those booster vaccinations. I did a rough calculation that every booster we get in now actually will probably prevent would prevent about every 10 boosters prevents 1 case in the community. Every 100 boosters, 100 to 200 cases prevents 1 hospital admission. And that is significant to us in the health services.
Brilliant. Thank you for that, Kelvin. We'll go to Oriana and then Mataroa.
Thank you, Chair, and thank you to the team for the presentation. Kelvin, can I just ask on your modelling, in terms of the Māori population, what's the percentage? Sorry, I missed the figures. So in terms of infection rates for the Māori population, have you got a...
Thanks, Ariana. There is just on one of our slides, Kelsey, if you could just put it up. I think it was probably, think about slide 5. It had the 4 columns and there were the Māori numbers there. So there are actual numbers. I haven't played around to pull off the percentages of those, but any disparity that we have in vaccination will actually affect obviously the case numbers and the hospitalizations.
And the reason I ask that is that if it's following the national trend where we are going to be, or the Māori population is going to have a higher risk than other populations, and in terms of Māori iwi providership, we're behind in terms of access to PPE, fit testing, people on the ground that are able to be mobilised to support families in need. So in every way you can think of, Māori providership are behind. And so our great fear is that we will suffer disproportionately because of that, and that is not a comment at all on our iwi Māori providership. As you all know, they've been working as hard as anyone else in terms of the vaccination clinics and trying to prepare our whānau as best as possible. But we do have a huge fear that we haven't done enough, and we're not doing enough in that space to prepare our whānau, even so far as having access to IT in terms of being able to self-monitor and do all the things that they need to be doing. So I don't have to spell that out for anyone in this meeting, but that is our huge fear, that we are underprepared for what is to come. And Kath is right, the locality hub has been stood up and is working well in Palmerston North, and we hope it's going to work just as well in the other localities as well. But as I said, we are scrambling for people on the ground who are able to fulfill some of these roles that are required as we move through this. So if someone was saying on the news this morning, you know, fasten your seatbelts, Māori have been fastening their seatbelts for the past few months in response to COVID, and we will continue to do so. So that's just a comment, but thank you very much for the presentation. That is actually fantastic. And we hope to share it, Kelvin, and I can talk to you later, with our wider Māori community. We do have our 2 p.m. stand-ups. That's since we've moved into the red traffic light, have been stood up again. We used them very successfully in the last 2 lockdowns in terms of sharing information with our wider Māori community, and it works very well. So we're looking forward to being able to have you on that one as well. Kia ora. Thank you, Chair.
We'd like to get Tracy to respond to a couple of the points in there, Oriana.
Thank you, Kath.
Kia ora tātou, my apologies for being late this morning. Yes, I agree with a couple of the points that Oriana is raising, and we're on to them quick smart. One of them around the PPE and getting access to the portal, and particularly getting our iwi and Māori providers ready has been a bit of an issue that I understand that John Whanga is right behind trying to fix up. The portal issue is a technical one, and I understand that it's happening nationwide. It's not just happening for the Manawatu, so we need to get that resolved pretty quickly. On the fit testing, we've got KU Anjaria behind that at the moment, just making sure that we get out to all the localities and work with our iwi Māori providers to get through the fit testing. Again, I agree, we've been a bit slow on being able to respond to this. And as you can imagine, it takes quite a bit to get people fit tested ready to be able to go out and do these tests. And also, we've only got a couple of machines in the district. So we're working really hard to try and get as many people tested as we can. And we have, as an OLT, prioritised our iwi and Māori providers, and then just on making sure. Sorry,
Tracy, I might just come in on the mask use though, just to remind people that even at phase 2, it's only high risk health workers who are into N95s, and for general healthcare workers, the advice remains to wear a surgical or healthcare grade mask. So that mask strategy may change, but at this time, you'll notice even within the broader hospital environment, we don't have everybody in N95s consistent with that advice. So just to reassure people, because the fit testing is for the move to that higher grade of mask.
Yeah,
okay.
And I was just going to end with having had a conversation with Kelvin this morning. He's very happy, Oriana, to come out to whichever forum you think Māori leaders need to be involved in to be able to have this conversation, and for iwi and Māori leaders to come back to us with any feedback on what OLT needs to do to support you in the developments and the planning that you're doing in community. Kia ora.
Thank you, Tracy. We'll move to Mataroa and then John.
Morena koutou. Thank you very much for the information and the update. It's great. I just had a couple of questions that I wanted to ask about what is our connectivity with Oranga Tamariki, because I imagine that some of that population are being referred to in that high risk category, and that's a complex arena for people to be isolating. And also around police with family harm situations in respect to isolation that people maybe placed in, because we know they were issues previously. And then also I just wanted to understand how we're going with the unregulated workforce for vaccinating and the ability to fully realise the opportunity that that provides us to step up our vaccination process.
I might come in on the points that you've raised around oranga tamariki and police Matiroa. So we have been through, Blair has been coordinating up until recently weekly meetings of public sector leads, chief executives and leads, because some of these are national bodies. So, and that's across the broader, including, because the boundaries are all different for the different entities and ministries, as you'd be well aware. But that's largely Manawatu, Whanganui, and picks up some other populations as well. So whilst there's a lot of national leadership and policies and frameworks for those entities, including you know, education, others, we've got good local relationships, and you know, we have been working through some of the challenges and matters that you raise, and those are very real, and they start, you know, you'd know that we hear from the Auckland experience and even from Wellington around some of those challenges. So what I would say is that the local people who are part of that call have consistently wanted to support us where we need that support, and you know, we can work closely with them when we've got those challenges. And so the key coordinator point is through MSD, and we work with MSD, but we can work back into those local leaders as well. It'd be fair to say the last couple of calls, I think Matiroa, you were probably on the other one, which is the RLG. Police have got a range of things that are kind of presenting challenges to them, including sort of natural events and that the protests. So they're a bit stretched at the moment, would be fair to say.
Thank you, Cass, and thank you, Matiroa.
Just the unregulated workforce question.
Tracy, do you want to come in on that one?
Kia ora koutou. Is that Chick in the room in Remu? Yeah. Okay, so just to let the board know that Chiquita, Dell and I met a week and a half ago just to talk about a few issues, including the unregulated workforce, and Selena. And Selena has taken it away to have a discussion with her ADON about how we actually go ahead and get that training into place and better support our iwi Māori providers specifically. I think we have 20 coming through in the first cohort, and we've got another 21 coming behind them. So Selena, do you want to add to that?
No, Yvonne, our ADON for education and training, is putting that in place.
Thanks, Tracy. I guess it's just the not just the training, but the ability for that workforce to enact vaccinating, because I understand it gives us a greater reach, and those are they're equity issues for the iwi Māori providers. So
that's absolutely true, Matiroa. And you know, we had some real concerns that training, you know, wasn't the big issue, it was the supervision and enablement of those people. So we had a conversation around that, and which led to the session that Tracy's referred to. And I'd really love to hear if there are any ongoing concerns or issues that you want to raise.
Well, I know Selena's working with Leslie on that. Did you want to update on that, Selena?
No, we're just, it's work in progress and we're moving forward, but there is a consultation process around that supervision numbers, and I think everybody's feeding into that process currently.
Can we have an indication of the time frame to resolve this matter, please?
Yeah, as soon as I get one, I'll get it through to you, Matiroa.
It just seems to have been taking quite a long period of time, and that's an essential strand for the iwi Māori providers to be able to stand that workforce up in a supported way. Consultation, I understand, but actually some action is required given the data that also Calvin has shared with us this morning.
That's the national, sorry.
I'll commit to come back to you by the end of the week in terms of where we are at and what our expected progress and enactment of this will be, because you know, I understand, as do my team, the critical importance of getting this right.
Thank you
The
very
nation-
much.
The national consultation is with IMAC, and that's
Yes.
around supervision numbers.
Yes.
And so that's I can't they've got timeframes and I can't change those.
I do understand that. I guess that what I'm saying is, yes, that's one thing, but what are we doing locally to support that workforce to stand up and start practicing? So that I'm happy with Cass's response.
Yeah, that's
Thank
what I
you.
will come back to you on the local, what we are doing, when we are doing it, and how we are doing it.
Thank you.
Okay, good discussion. Moving to John.
Kia ora, Kelvin, thank you for your figures. I'm reassured that given 70% uptake of the booster, you're predicting 11 and +2 in ICU. But from our experience with Delta, I'm just wondering if you based your infection rates in Māori on what we're seeing now or what happened with Delta in South Auckland. If it's close to what happened in South Auckland, expect numbers of Māori to be higher. And if so, I think that if I suspect is correct, and that more Māori than you're anticipating will be infected, I think that puts even more pressure on Māori providers and perhaps makes it actually more urgent to make sure that any protective measures we have in place are brought forward as soon as possible. So back to my first question is, your estimation of 11 and 2 in terms of being admitted to ICU, is that based on our Auckland figures or based on current Omicron figures?
No, that was solely in and around vaccination rates and risk estimates. I do understand that when the ministry put that modelling tool together, that they took a number of working activities that had come out of Manukau, so it influenced it, but it wasn't the whole picture, John. I'm happy to pass on to you the specifics if you would like.
Thank you for Kelvin. My concern is if rates of infection are higher in Māori, that's going to place Māori providers or those dealing with Māori, which principally will be Māori providers, on the back foot in terms of their preparation, their protective preparation.
Yeah.
Okay. I think we'd agree that there has that one presentation has stimulated some significant constructive discussion. And of course, it's clearly the highest priority for us all at the moment in terms of what's happening in our community. We have a recommendation to note the planning update, and I'd just like to find a mover and a seconder. Just bear with me while I get the screen on. Hold on, small technical glitch. Can somebody wave? Right, so we've got Jenny and John. Okay, move Jenny, seconded John. I'll put that in favour. We'll raise our hands, and against, it's carried. Right, sorry about that. Thank you, team. We're now moving through to the CE's report.
Well, a big chunk of my CE report was all things COVID, so we won't revisit that, having just had a chat about that. So maybe what I'll just do is open it to any questions that people might have of any items that are within this.
I think that's the fairest and purest way to go. So John, first question.
Oh, it's not a question, it's really a commendation. Thank you, Kat. Look, it's a credit to your leadership and working with Te Tihi and Māori providers that we are seeing a much greater acceleration in the Māori uptake of the booster. So I'm just hoping it continues. Thank you.
Thank you, John. Are there any Karen?
Thanks, Brendan. Just a quick question around the Spire, the progress with Spire. Just the delays that have been mentioned. I'm just wondering how that has, what sort of impact that has on the mitigation that was put in place for delivering surgery throughout the process of implementing Spire.
Doesn't have a significant impact, Karen. You know, we have built contingency into this project as you'd expect, given you know, when you open a wall or a roof in an old hospital, there are always some nasty surprises lurking. So at this time, we're not feeling concerned, but we do, of course, have the risk of COVID potentially impacting this workforce and this project, and that is something that we're very mindful of and that we'll need to be aware of as we go forward. We had a walk through recently with our medical leads and our MRG to have a tour of the first stage, which you know, people on the whole were really happy to see that, particularly impressed by the windows that they now have, because they don't have any windows in the current theatre environment. So the first stage recovery for patients, beautiful windows for people, the staff area for tea rooms. So I know those seem like small things, but they are quite a big thing to that workforce who are working in the dark pretty much for a whole day. So so it's moving along. Alberto has done a big piece of work now to continue modelling out the impact on patients' access to surgery at the conclusion of the project, and it looks fantastic. The impact that it will have on people getting access to surgery is even better than we had first thought. So together with the 5th Theatre at Crest and the other work that we're doing at Crest, you know, we're confident that when this project's finished, our community will be in a far better place.
That's really good to hear. Thanks, Kath.
Thank you, Kath. Muriel?
Thank you, Brendan, and thank you very much for the report, Kath. I've just got a minor question on page 11 around the leadership, the clinical executives in Te Uru-Arato, and just wondered if we could know who those 2 people are, if they're in post already.
Oh, right. Well, it probably won't be a great surprise, actually. So we've got Hargai Weinberg in the unplanned area, and Alberto Ramirez in the planned care area, so supporting Lynn. So they are now in post, and the next area that we have yet to do to finish our recruitment to is the one up above, which is the clinical executive and medical lead roles in Te Uru-Rahui.
Okay, so the medical reference group, the senior medical officers, there's the feedback from them about this being positive, like they've supported the change?
They certainly have been part of the process, no doubt. I'm very happy.
Thank you.
Okay, Kath, I think that the presentation prior has stolen all of the thunder out of your report, and clearly the way the report has been presented, I think gives us significant confidence in the work that's occurring. That said, we do accept that it won't be perfect. There will be glitches as we go through this Omicron challenge. And I think the key thing is, so long as, whenever an issue arises, we appropriately get it to whoever it needs to be gotten to, so there can be a constructive action against that. So, and I think we've done that really well to date. I know on occasion there's been particular concerns in a community that might have got to a board member, the board members been able to feed it through and action taken. That's just eyes and ears stuff. So I know the report's detailed. I know there's not a lot of questions, but I think we understand the relevance of that compared to based on the earlier paper. You might want to finish out, Kath.
Yeah, I might just say one last thing. Our approach, our social media strategy and approach has been getting us a huge amount of positive feedback in the community and from our stakeholders. So, you know, that's been really heartening. We've been incredibly proactive in that space. We probably won't be having as many regular updates during the day now that we're heading to a stage where there's going to be just lots of COVID everywhere. We'll probably move back to a once a day on our Facebook page. But when we were sort of starting to see it for the first time, you know, that sort of messaging to the community about being aware, being tested, being vaccinated. And we'll continue with those messages, but we probably won't be pushing out several times a day.
Okay. So we've got a resolution to note the CEO's report. Can I just have a mover and a seconder, please? Moved by Muriel, seconded by Karen. Put that, we'll raise our hands in favour, and against, there's none, carried. Right, we're going to move to the financials. So just so we're clear, the financials will be the package of the 3 months. We're certainly not going to go through each of those individually. So we'll pass over to Neil. Now, I understand Daryl's not here today. Neil?
That's correct. Unfortunately, he had an appointment he had to keep, which I've agreed is the best thing for him to do. So you've got a poor substitute in me. Please no tough questions. So if you'd like me to kick off. Look, I'll talk to December. I have to say that, at this point in time, the preceding months are becoming a dim memory. However, they had set quite a good pattern in terms of positive variances against operating budget for the month. December turned that around. As board members will be aware, January we've actually had a reversal back in the right direction to catch up some of December. In fact, caught up more than December. So focusing on the month, December was a $3.26 million deficit. Now that was 872,000 adverse to budget and operating level. Not so bad off when you add back the positive contributions from the one-off items. I think quite importantly, if you look at the trend that's showing up on page 3 of the finance report, and let me just pull it up so I can keep my reference as I talk through the results are tracking pretty well the budget. So they're over and under, but they're not a different pattern to the budget, which is quite comforting in the sense that I think for another year we've got quite a good predictor there in terms of what the overall pattern will look like for the year. And then the rest comes down to variation and things that have actually happened in real time. What we actually have here, I think, is we had a gross up in terms of pay equity, which affected both revenue and cost. But really the revenue side was planned care, which was down with some counter to that from minor procedures that were pushed through. We've got backdated MECA costs in the showing up in the particularly in the nursing line. We've actually also got, I think, nursing costs that are reflecting through the fact that we are totally hammered in the hospital in terms of the need to keep it fully staffed, and the nursing FTEs are in total up by about 10. That's reflecting through, and of course there are other impacts there pushing up costs as well. So we also had the adverse costs here coming through from locums. Our ongoing trend of struggling to get SMOs into mental health is continuing to show through there. Overall, I think if we look at the personnel side of things, FTEs are tracking under budget, but they're not tracking away from the budget. They're actually just trending with it, just not about 30 short. That's probably not a bad place to be, actually. Good cost containment without actually having the business staff and people. But the detail, of course, is that some areas are better recruited to, and others we're struggling to get the numbers we need. Probably nothing surprising in that pattern. The only other things worth noting, perhaps, are that we've had again another month where we've had some high costs in outsourced radiology and bloods, both affected cancer services, and our professional fees of about 200,000 off pace. That comes down to quite a lot of reconsideration work around things like digital and enable mental health services and a few other things that have come through and affected that line. And that's probably what's on my mind. I'm happy to respond to questions.
Thanks, Neil. Are there any specific questions in relation to the financials? We all know the challenges that we're sitting in front of us. There's nothing glaring in there from my perspective that says we've got a major issue that we need to be alerting, that we need to be alerted to. We're there or thereabouts on our target, and that's what the minister's expecting from us. No, we're all looking pretty good, Neil. Looked like you got away with it.
Sure. Thank you, Brendan. And I confirm your sentiment, by the way. It's feeling like a business that's tracking, plus or minus a bit, around about what it should be under, quite difficult circumstances. So
Fair summary. Fair summary.
Right.
So with Vaughan.
Happy to move, Chair. Obviously, this has all gone through FRAC as well, so I'm happy to move. So
you're moving all three in block?
Yes.
Okay, thanks, Vaughan. And a seconder, Muriel. Sorry, Heather was quickest. So Vaughan and Heather. So we're in block. I'll put that in favour. We raise our hands against. There's none. Carried. Brilliant. Thank you. So we're now going through to the sustainability plan. Here we go. Where's Gabs? Welcome, Gabs.
Hi, morning everyone. There's been some nice progress since the last report in November. Since FRAC, we've just had a little change in the savings for the year. Daryl was able to update the table and the savings. The biggest risk still remains around the skill mix project that we have, and part of that risk is understanding the potential models of care, particularly going into a Health New Zealand environment. What is the operating model, which we don't actually have eyes on? I'm happy to take questions.
I think just as an observation, we established this program, just correct me, prior to COVID. The original concept of the sustainability plan was prior to COVID. I think it's worth reminding ourselves of that. We're still trying to deliver it in incredibly challenging times. Just imagine if we didn't have those significant distractions to where we would be compared to those original objectives that we set out. So, I think you've got to acknowledge that sort of stuff because it's an impediment to the objectives that we're trying to achieve. And frankly, whatever it is that we can achieve at the moment under the circumstances, I think is outstanding. But I just feel it's important to just remind ourselves. So Muriel, a question?
Thank you, Brendan. You stole my thunder. I was going to say something very similar to that.
Say it anyway.
But I had noted as I went through the report that there's a few amber areas in there, but there's no red, and there's been generally good progress. And in light of everything else that we're facing and doing, and whilst the savings we might have wanted to make from this are quite a long way behind year to date, I think it's still a very positive update to read and appreciate, and thank everybody for all the work that's going on around it.
Thanks,
well done, Muriel. Now there's multiple hands, so we got John, then Oriana. Okay, John and Oriana.
Oriana, you first.
Oh, you've gone on mute, Tori.
Right, that should be just a really quick comment that the report notes that, a lot of these timelines have now been pushed out to 2023, and I have every confidence that we're going to get there.
Well done,
John. Just to note in Appendix 1 down at production planning led by Daryl Ratana, how portable is that, given that it's almost completed? Daryl, how portable will that production planning, because it seems to be quite key to how we manage or how the Health New Zealand manages in the future around here?
Well, Daryl's not on the line, but from the discussion that we had yesterday, the production planning has been submitted. And I think Neil's just popped off as well. There has been some planning that has gone through to the transition unit about our situation going forward. So take it from that, it is quite portable.
I think I'd go further actually, John, and say production planning will be a more critical element of the new system because it'll be activity-based funding. So rather than population-based funding, so it's portable, it needs further development nationally, and I expect that that will be a focus going forward.
Right. We'll move back. We'll move back to the recommendations to note, endorse, and approve. Is somebody prepared to move accordingly? So Muriel Mataroa, moving in block. The recommendations, I'll put that in favour. We say aye, and against it's carried. Brilliant. Thank you very, very much, everybody. So we're moving to the health and safety and wellbeing report, and Kayur, I think, is going to be able to assist with answering some of the questions earlier on that Karen had asked, and I think he's been alerted to that. So we're in your hands, Kayur.
Kia ora, morena, everybody. The quarterly health and safety report for the quarter ended December last year. Essentially, no notifiable incidents. Overall, quite a settled quarter from the health and safety perspective. A lot of movement and a lot of effort in the COVID space, especially the vaccination orders and implementation of the first and second dates of the vaccination orders, that and also the pickup of staff protection in terms of vulnerability assessment and fit testing. So that work's actually taken away a lot of effort over there. However, before I get into that, just wanted to know that we still continue with a small program of work in terms of trying to reduce the number of patient-related musculoskeletal injuries. A small project group that is in place seems to be showing some difference. It seems to be having some impact, but I'll closely continue to monitor the musculoskeletal injuries for staff. And that's really been well received, because we have a champion, moving and handling champion from theatre, who is helping with this in conjunction with a physiotherapist and the occupational health nurse. So 3 of them forming a small project team and working on that and seeing how that particular project works. I have been asked to stress a little bit more on the sick leave, the increase in sick leave, which has been reducing from just above 4% to a lot lower in October, which is when we started receiving information about the vaccination mandate. And as we all know, we had a significant number of people whom we were managing through this entire process. Some of them we had to terminate, unfortunately, which is not a great sign. But since we went into this entire period, including the period of notice that we gave them on the 5th of November, almost all of them went off on, I'll just decline that one. Almost all went off on stress-related sick leave, which has shown that spike across November, and that dropped once we, because the first deadline was the 5th of November, which is where the majority of the people had to be managed, and that dropped off a little bit across December as people's notice periods started coming to an end. So that kind of explains that small spike in sick leave and stress leave. And because we do not have a separate category of stress leave, it is basically all sick leave. And I have medical certificates. We did receive a lot of medical certificates from these staff who were impacted by the vaccination order. Just wanted to focus a little bit more on the respirator mask fit testing. We now have what I believe is sufficient in terms of equipment to conduct fit testing after a significant period of time. We've got additional fit testing machines and staff coming on board over this week and next, wherein we will be able to almost double our fit testing capacity. We have just around 200 staff, frontline staff, who are yet to be fit tested in the DHB, which means about around 90% of our staff, if not more, have been fully fit tested. We're still following up with those who are not fit tested, but we have had multiple reminders being sent to them. They're just some of those who will probably need a lot more effort. We also have a few staff who are persistently on night shift, who will need to be fit tested. And now with the resourcing up starting to climb up, we're going to put a fit testing availability for at least a couple of night shifts. So that is going to cater for those staff who just only work night shift. There are a few of them who do, and we'll continue to work with that. In terms of Maori providers, at FRAC, it was pointed out that we need to extend that the fit testing to Maori providers, and we have commenced that process. I will have to move you to this screen in order to. So we've completed about 36 of them of this across Tararua and Palmerston North on the 11th, but we could not make the date of the 8th that I had mentioned in my report. But we have some plans on the 16th, the 21st, 28th, 1st and 4th of March, and we are going across Tararua, Fielding, Otaki, Horowhenua and Palmerston North to offer fit testing to them. We've also been offering fit testings to our students and contracted workforce. So most of the frontline contracted workforce is already fit tested. I'll probably take a breather on that and pick up questions if at all, and then continue to go if I have to talk about the staff shortages. Brendan, you're on mute, sorry.
Yeah, thanks for the overview, Kay. I'll just check in to see if there's any questions. Are we all good? It looks like, oh, Karen, sorry, I knew, got you. Karen?
Thanks, Brendan. Thanks, Kay, for your report. Just in terms of the vaccination mandate and with the booster also being a requirement now, is there any understanding of whether there are staff who won't, that aren't sort of going to be compliant with that?
So as at yesterday, we have 70 staff who have not yet been boosted, who were eligible. However, the eligibility date has been pushed out from the 15th of February up to the 24th of February. So we are interacting with them. Many of these staff, I'm looking behind because I've got the stuff on my whiteboard over there. And in fact, I also have people who are not eligible down below over the next 6 months. So I have the whole eligibility over the next 6 months with me in front. So I apologize, I should probably had it in front of me. But we have about 50 nurses, 4 registrars, 8 allied health staff, 1 midwife, and 7 management admin staff who are yet to be boosted. I have been in touch with them. Many of them have already booked in their boosters. And I know as of this morning, that figure has dropped further down from 70 to either low 60s or high 50s. And we continue to interact with them. So far, we haven't received any indication of staff saying, I'm not going to get boosted. It's just about giving them or finding the time for them to do it. I mean, that's the kind of feedback we've been getting, like, yeah, I'll get to it kind of stuff. And that's where we probably need to be a little more realistic in how we approach it. However, we do know that we have a mandate and we have to meet the deadlines with that. But luckily, that's been extended out until the 24th.
Yeah, that's good. Thank you.
Vaughan?
Thank you, Brendan. Just in regards to the staff and the staff vacancies, were you going to cover that again as a separate piece, or?
Oh, sorry, I should have covered that. Yes. So as you see, we did lose some HCAs and nurses in addition to the normal turnover that we have, but there's been a lot of effort, and I think that's the last part of my board report that I wanted to talk about. But when we look at it, when we look at this and we look at the overall positioning of MidCentral nationally, I accept that there have been we are at a negative variance. But we have put in a fair bit of effort in getting into those recruitment activities. There was some talk about limited MIQ spaces, but that's not true because we have dedicated MIQ spaces available for healthcare workers, and we have been availing those on a regular basis. So I think the staff shortages, especially with resignation and the negative variance, should probably be read in context with where we stand nationally.
Thank you. Are there in Vaughan?
Yeah, thank you, Brendan. Just in regards to that, just understanding over the Christmas break and that we've had some staff shortages, just the overall feeling amongst the staff around being able to take leave or take their breaks just to keep fresh for the task at hand. What's the feeling like across the floor? Is there any monitoring of that?
Yes, so I was looking at the overall annual leave consumption over the December, January period, and the annual leave, as always, has dropped. So leave was approved on the caveat that it could have been, it could be cancelled. So we were encouraging staff to take leave during the Christmas New Year period. And as I'm just clicking on to see very quickly the annual leave rate, but the annual leave rate the annual leave consumption has increased, and the amount of annual leave consumed over December and January has also dropped. So yes, it is evident that staff have been taking breaks, and the leave is quite, the drop in leave is actually quite consistent over the last couple of years.
Okay, and with one of the feedback coming from staff around doing extra shifts over and above what they're normally rostered for to cover the care capacity, are we doing some monitoring of just how many extra staff, just in regards to burnout or just into fatigue and health?
Yeah, so I think that's something that we normally monitor in terms of overtime. And again, overtime graph in front of me. So the period, so we had about 60 FTs, but even the overtime graph has been dropping. And in the workforce report that I provide, I will obviously talk a lot more and in more depth and detail about overtime rates as well. But I can see the overtime graph in front of me, and it was down from 60 down to 45 in December. So I have that in front.
Okay, thank you, Kaya. Thank you, Brendan.
No worries. Kath, can we just check in? Is there any other questions we need to check off on?
I might just I just wanted to comment on the question that Vaughan raised, because I think it would be fair to say, Vaughan, that we have a very stretched and stressed and under pressure workforce, and we're not unusual in that. All DHBs are experiencing that to one level or another. And we are very mindful of that, and we do check in with our workforce regularly. We've probably been more successful than most of our other DHBs in our nurse recruitment, which is fantastic, but you're well aware of where the pressure points are and the challenges that we've had, particularly around bringing workforce across the border, recruiting. We do have ability to get dedicated MIQ, but there are people who are less willing, I guess, to sometimes shift into a different country if they're not sure how they're going to visit family and friends once they get here. So it has been a challenging time, and of course there's quite a lot of apprehension about the weeks that are in front of us. So how we support our workforce, how we support people's resilience and well-being is something that we are, we're really mindful about and thinking about.
Yeah, thank you, Kath.
Well done, Kath. I think that covers us off, Kaya. So we'll go back to the resolutions which are to note, and a mover for that, please. So moved by Vaughan, seconded by Heather. Put that in favour where aye, and against we're carried. Thanks, guys. So we're now going to move to the decision and discussion papers. Is Simon coming in for the clinical council? Look at that. So we'll just wait for Simon to connect.
Brendan, while we're waiting for him, could you please send me the links for part 2 and part 3, please?
That's a step too far for me personally to do that. I think you understand my technological prowess.
It's fine. I can do that for you, Lou.
Oh, I sent you a message, Margaret. You haven't got it. Thank you.
Thank you, Margaret.
Margaret, Heather here. I can't find them either. Did you send out separate links?
Yes, I did, but I will resend it.
Thank you.
Thank you.
Okay. So kia ora, Stephen. Good to see you. We're just looking for Simon. How are you going, Margaret?
Yeah, he's been admitted. Must be having trouble connecting.
Okay.
Kia ora,
So,
Brendan, kia ora koutou.
Stephen, I think what we might do is move directly to your report, and then we can go back to Simon rather than holding people up.
Sorry, Simon's arrived.
Oh, Simon's arrived. Gosh. Well, given that Simon's arrived, we'll take your report first, Simon. We'll stick to the schedule. Welcome.
Thank you. Trying to keep the wheels of health turning.
Yes, I appreciate that. I do. I genuinely do. It's pretty obvious you are in a different role at the minute. Do you have any observations you want to make, Simon?
The only observation really is it's an interesting time of change, to some extent paralysis. So I think our focus really has to be on our key objectives that are continuing to move forward. So equity, IT, mental health, to some extent integration and staff welfare, those sort of areas.
Look, it sounds terrible to say it, but we all completely understand the stress and the strain. And it's really, really, it's quite challenging at the moment. The reports that we've got, but, there's an element of pain in them as well. And it's really, really difficult to determine how, in a forum such as this, how we specifically respond other than to acknowledge, it's tough. It really, really genuinely is. And we've heard that, for at least the last hour and a half since we've been on this, we've been on an hour and a half. So the similar themes are prevailing, I suppose, would be how I would summarize. But I just will check in to see if there's any specific questions or observations other than which have already been made. I think we're all, we're all on the same song sheet at the moment. I suspect your greatest interest is to get out of here and get back to the coalface.
That's it.
Yeah. So let's acknowledge that, and thanks for the effort to get the report in, and also genuinely acknowledge what's going on in the back room there that we, the public, don't get to see.
Yep. Thank you, and I appreciate that your guys' task is also a bit hamstrung.
Cheers, Simon.
Thank you.
No worries. Thank you. We'll just move a resolution to note the clinical council report, moved by Karen and seconded by Lou. In favour, we say aye. Against, we're carried. So we'll go straight to the Consumer Council. Stephen, welcome back.
Yeah, thanks, Brendan.
We're in your hands for any observations you may wish to make.
Okay, well, thanks, Brendan. Yeah, I have got a couple, but now I'm a little bit nervous because I heard your comments to Simon, and I guess I'm going to say a few things that probably add to your stress and the things that you've raised this morning. So I'll just see how we go. Firstly, I want to apologise. I don't think my report's very good at all, and I know that, and it was actually deliberate because I've got another apology, particularly to management. there's a couple of comments I've left out of the report that I'm going to talk about that I guess I've broken protocol by not reporting it to management and breaking that convention, and no surprises, but you've probably heard these before, and I take it from your comments that you know, I'm going to add to that and not be helpful. But before I do that, I just want to acknowledge Gail Munro, who was chair of the Consumer Council, and you know, I really respected Gail as a leader, and as did the other council members. She was absolutely passionate about her job as chair. She was a very good chair and dedicated to her role in the Consumer Council as chair of the Consumer Council. So I just want to acknowledge that. Now, the points I want to raise are about two things that have happened in the last, or came to our attention in the last, one goes back a little way, and one was certainly in the last 6 months. And the first, I'll mention the most recent one, and that was a presentation by Dr. Philip Seustedt. I think I've got the name right. Now, some of you might have heard his presentation before, and I think I've got a duty to follow it up. He presented a story to the Consumer Council that involved an extended whānau led by a matriarch who, the whānau was in that lowest socioeconomic decile. There were gang affiliations, there was domestic violence, but he learned of this family through an appointment that he had, and we had a DNA, so the person didn't turn up, and it would have just been left at that, except Philip said, I need to see this person. He had some tests in front of him, and it was vital, absolutely urgent that he saw this person. So he took it upon himself to make contact with that person and get them in and you know, have a consultation. He then connected with several other members of the family that also presented over a period of time to Palmerston North Hospital. But through that initial contact, he developed a relationship with the matriarch of the family and built the trust of the family so that he could actually work with them, and he was given permission to tell his story. Well, I haven't got permission from that whānau to tell the story, so what I'm going to do is encourage you to get Philip to tell you the story. But it was a heartbreaking story, and talked about, you know, some of the breakdowns in the system, and he's dealing with that. And I guess as a result, he came to the council somewhat out of desperation, exasperation, and really a cry for help. And I felt that if I didn't tell his story, that I'm actually letting him down and his whānau down. And I think this is a classic case of inequity in action. And if I'm remiss in the way that I'm presenting this by not putting it in the report and just verbally telling the board, well, I don't know whether I should apologise, because you had to hear the story to believe it. And we all felt that story. Every single one of us, you know, got the message, I think. And thanks to guys like Philip, you know, I think things are changing. So that's the first story. And the second story I want to tell goes back probably a couple of years, but they're related. And that was a presentation made by Dr. Curtis Walker, I think to the combined clinical consumer council. So we meet combined meeting every probably 3 months, quarterly. And I think he was he had a position representing the combined medical staff, if I remember correctly.
Correct.
And it had to do with the facilities. And I know that you're aware of this, and I know things have changed, because since then, it goes back a little while, and we have the Spire project, and we have a building project, but essentially the complaint was around the facilities that, the staff were working in. But he gave an assurance that if the staff could see these problems being addressed, that they would be happy to continue on. And again, you really need to hear from Dr. Walker. But I guess in summary, the way I see it, in my position, stories that come to us, that we've got passionate, dedicated staff who are doing a great job. But they're undermanned, under-resourced, and working in inadequate facilities. Now, you're probably aware of some of those things and some of those comments. And I also know that you don't want people like me coming along and telling you we've got a problem that you already know about. You want a solution. And look, I don't know that I've got a solution, so I apologise for that. Because some of the decisions that have to be made at a level above you, at a political level. But I think what you need to do, well, collectively, we all need to do is stand up and push back on those politicians and tell them that, unless we make some substantial changes and greater investment, the staff particularly, who do a great job right across the board, are just going to give up in sheer frustration. Now, I also take your message because you've got COVID knocking on the door, and in a big way. It's ready to smash the door down, and you're going to be faced with even greater problems. So you don't really want to hear all this from me. But anyway, as I said earlier, I felt in the role as acting chair, if I don't put these views across, that I'm letting both Dr. Seustedt and Dr. Walker down, as well as, I guess, the rest of the staff and the community. So sorry, Brendan, that's my rant. It wasn't in my report because I didn't want it edited. And now you've heard it. So happy to take any questions about that.
Got it, John. Look, you don't have, Stephen, you don't have to apologise at all. In fact, I'll acknowledge it in this way. You've got incredible mana, incredible integrity, and you are hugely respected. You have brought a message that you have brought with a level of credibility and real passion. So you don't have to apologise, Stephen. That's not where it is. What you've articulated there is fair, reasoned, and appropriate right at this moment. I could easily say, look, we've heard all this, we hear it often. Yeah, we could wash it off, but we won't. We'll take up that challenge that you have placed there to determine what is it that we might want to do in terms of responding. I just want to choose my words carefully. Every week every Friday when the chairs of the DHBs across New Zealand gather in a format exactly like this on a Zoom, it would not be unreasonable to observe that any one of those DHBs would have stories of a similar nature. And so that's the great challenge that we have. How do we specifically respond in this case, and how is it that should be responded from a higher level? Clearly, from a higher level, there's massive change coming in front of us, massive opportunity, hope in most people's minds about what it is that's going to occur. So I would like to think that that's a sense of response, but it's not for me at my level. That's further up the food chain that need to be making those observations. Those real heart-wrenching, deep in the soul stories, they hurt. And they hurt in a number of ways, depending on how people receive them. For people such as myself, it's incredibly difficult to know how to actually get the response appropriate. Really, really difficult. For the bodies such as the one you represent, you would hear way more of that than what I would. And it's how we go about responding. So I just want to make that acknowledgement, because you are highly respected, and you're not out of order with what you've done today. There are a couple of questions, so we'll just go to, I don't know who put their hand up first, but I'll go Heather and then Karen, because that's how it is on the screen. Oh, and Mataroa next. Heather, Karen, Mataroa.
Stephen, thank you for your candor and your honesty with that report. I have to confess that Gail had also referenced to me, I think, the scenario that you talked about with the doctor who made contact with the whānau's matriarch. So one of the things that occurs to me as you were talking, obviously that action, that very proactive action, was a circuit breaker for that whānau, and allowed communication to happen. And I'm hoping, so I don't know the story, Gail didn't disclose it all, but I'm assuming it led to some resolution and a much better relationship with the whānau, and an ability to work with their health and support needs. And I think the key thing there is you say you don't have a solution. I think that you do. The solution is telling those stories and looking at what was it that worked. How did that engagement happen? And what was it that worked was the tenacity of our medical teams and their trust in taking that story to you to be heard and using it as an example for future engagement. It is beyond the influence of individuals to change the system. That is a political issue, to change the resources, the facilities, the system. But what is within the grasp of individuals is to be honest and communicate and engage. And I think those are the solutions. And when people know that the system is a system, but the individuals within it have hearts and care, then they're more likely to respond to the system. So thank you. And we need to hear those stories so we can look at what was it that worked, not what was it that didn't work, but what was it that worked, and how did this whānau now come into the system, and was it effective? So thank you.
Look, just responding. Look, first of all to you, Brendan. Look, thanks very much. I really do appreciate your comments of support. Heather, I don't think there was a question in there, but what I would say, and I guess Philip would confirm this, is that members of that extended whānau have now got confidence, to come into the hospital, approach the GP, where in the past we wouldn't have seen them. So that must be a positive. But the other thing I'd probably add is that I'm going to ask Dr. Philip Sewstead if he would come again to the Consumer Council and perhaps update us.
Well done. Karen?
Thanks, Stephen, for what you've shared, and I obviously share Brendan's comments in terms of how valuable that is for the board to hear those unedited accounts. I think I was on the board when Curtis Walker presented, and so it was really useful and valuable to hear his reflections. But I was just going to suggest whether it might be appropriate for us to invite Dr. Sewstead to perhaps be able to do that presentation with the board, Brendan, perhaps either in place of a consumer story or at an HDAC meeting or at some opportunity in the near future. I think it's always useful for the board to hear that, and I'm just based on what Stephen said today, I wonder if that would be a valuable presentation for the board to hear.
Yeah, sure, we can explore which format might be. I'm thinking HDAC, but we'll explore what option, Karen. Yeah.
Thanks, Brendan.
Okay. Mataroa?
Ngā mihi, tēnā koe, Stephen. Thank you for the kōrero this morning. And yes, they're powerful accounts of the trauma that whānau experience when they engage with the system. And as you rightly point out, the tenacity and the caring that occurs from the clinicians is crucial to resolving those things for whānau. So we know that that is part of the solution. And we certainly, well, I certainly appreciate those people who work in those fields and approach their mahi in that way. Forever grateful for them. I did kind of want to pick up, like I agree with what has been expressed by Brendan and Karen and Heather, and perhaps the opportunity for Phil to come to a board meeting. I was just wondering whether or not there is an opportunity to raise the issues to a higher level, if you like, by way of, as a board, we are almost done. However, we have this information being put to us, and I wondered whether or not we had an opportunity to write to, the Director General of Health and the Minister and express not only our concern about these ongoing challenges in the health system, but also to highlight the kinds of solutions that were undertaken by the kaimahi in this situation, and promoting that with the change in the way that the system is going to be re-engineered is the opportunity for these matters to be taken more systemically in relation to the changes. I just think we could write. We are definitely within the scope of our remit to be able to write, not in a rude manner, but in a respectful way, but highlighting the truths and supporting also the work that is going on by clinicians, and expressing both our thanks and our desire to see these things more elevated.
Mother, I think that's a highly constructive, proactive opportunity that's actually saluting the work that's been done. So I can't see any reason why we wouldn't give some, that thought be given to a constructive letter that is, that's profiling an initiative that has a proven outcome. So so there you go, Stephen. You come in here with a little bit of a grumpy approach, not quite sure how well you're going to be received. You've laid on the table. You've had some, I think, some really I would say, quite special responses from board members, and culminating there with a productive, constructive suggestion. And I see Kath's keen to comment as well. So I'll just go to Kath and then we'll give you the last word, Stephen.
Thanks, Brendan, and thanks very much again, Stephen. I did wonder if it might be able, if we might give you a little bit of hope though, because that story is well known to us, and there have been things that have occurred more systemically in our system, you know, as part of our broader, I guess, commitment to Māori, to Te Tiriti. And Brendan, if you know, if we could just take a couple of seconds for Tracy maybe to give some sort of hope for how we have taken that story as part of our broader, I guess, learnings and the further work that we've been doing.
Brilliant, thank you. Yes.
Kia ora again, board. As long as we understand that there's a difference between a sprint and a marathon, right? So there's a lot of work that is going on, particularly with this whānau. And can I just let the board know that I have a direct line to Philip Suisted in terms of some of the things that he's finding in the system, and our Prioritization team is picking them up immediately and working with the whānau and dealing with those particular situations. Although we're very clear that these issues are systemic and there are stuff that needs to be taken nationally. I completely agree with you, Matua, Stephen, but there's also some things that we could be doing very easily in the system, and a lot of it is related to behaviour and attitude. So we are working with staff who we're identifying that are discriminating and doing things that they shouldn't be doing in a particular way and ill-treating our whānau. And look, it does get heated. Our team is the meat and the sandwich sometimes when we have these discussions, but also I've got some very strong partners in the OLT who are actually challenging some of these behaviours. It's happening in the COVID space, it's happening in ED, it's happening on the maternity ward, it's happening in GP practice, it's going on everywhere. And we're trying to keep up with the individual stories we're hearing, but we've got to stop chasing our tails, and we've got to have a strategic direction for how we actually manage cultural competency and dealing with our whānau. So this is the work that Paiora is doing now. We've got a facilitation team out who's working with the family. We're bringing in new facilitators, thanks to the board for the equity funding that you've placed intact. We're putting in nurses that then become bridges to iwi and Māori providers and GP practice for high needs deprivated populations, making sure that they're enrolled, making sure they're registered into Māori and providership, and ensuring that we give warm handover to ensure that our whānau are getting the services they need. However, you get to the other end and we haven't got enough GPs. So we need more Māori nurse practitioners, which is another program we're developing inside of Kaimahi Ora Whānau Ora. I want you to know as a board that in the last quarter, we have recruited 55 new Māori people into our system. That's stunning. And I'm not sure of the numbers externally, but we're slowly trying to catch up with the problems. But you've got to understand that the discrimination and the racism in our system, which is profound in the report in Y2575, is a long game that we need to stay on top of, and we need strong leadership, not just Māori leadership, but we've got particularly strong iwi Māori leadership in this district. But we also need Pākehā leadership over this, and we need you to call it out as well, which is what Philip Stuisted is doing. So I really thank you, Stephen, for your leadership in this space and for bringing it to the board and doing what you're doing. But we have to get real now. We've actually got to make some hard calls. You made one last year, which was giving me $5.3 million to prop up the resource into Paiora and into iwi Māori providership. And we have to keep going. This is a system change approach that requires many stop point and changes, which we're trying to do in a categoric way to ensure that we don't lose anybody anywhere. We're placing Bonnie at the ED front door to make sure that the discrimination stops there, and then we're following that through with David Prisk, who is thinking about how do we improve the triaging of Māori 4 and 5s into ED so we stop the did not waits. And we're staying on track with Te Ara Angitu to be very clear about where all those problems are so we can do the deep dives. But I need your help at the governance level to make sure from a monitoring perspective we're on top of this. Thank you.
I think we all should take a deep breath after that. That was, and that's recorded. So Tracy, that was absolutely stunning. Brilliant, brilliant oratory.
There's a massive program. There's a massive program going on around this, Brendan, and we're identifying the issues.
I mean, I can see everybody on the screen. There's a hell of a lot of nodding of heads. So well done, Tracy. Fantastic. There you go, Stephen. I'm going to go back to you for a minute, and then we're going to move on. Otherwise, people will give me a apology for being late.
Look, I guess one of the other highlights in my time was the strategy refresh that the board did, and I was part of, and that gave me great hope then that, you know, equity is right at the forefront. And as, you know, Tracy's outlined, you know, I accept that what she's saying. And I just want to say thanks to, you know, to the board for listening to my rant this morning. And, you know, I was very nervous before coming on. So look, thanks very much for taking that on board. And thanks to everyone in the team that, you know, is doing their little bit.
Got it, Stephen. Thank you. Yeah, Nama. We need to move through the papers, guys. So can we have a resolution to note the contents of the Consumer Council report? So moved by Muriel, seconded by Lou. I'll put that in favour. Aye. Against, it's carried. Thank you, Stephen. We're moving to the CMS Executive Action Plan. This will just be a relatively rapid update, I would imagine.
Yeah, so there's one item that you will have noted was for discussion at our recent MRG meeting, yet to be concluded, and we had an agreement at the recent meeting as to how that piece of work would be concluded. So Kelvin will work with Natalie and the team to, in a meaningful way, conclude that piece of work.
Okay.
You know,
Thank you.
That's the plan.
Okay.
Yeah.
Nothing else? Any questions? We're all good. So we just have a resolution to note the action plan. Hold on, just got to check my hands here. We've got Heather and Karen have got hands up. Are they still alive, or are they? No, Karen, are you?
Oh, it's just a quick question in terms of that outstanding action. Were the CMS still wanting any ongoing engagement with the board over the matters that they raised with the board?
I think the CMS would probably love to talk to the board at every opportunity they could possibly get, Karen.
So I guess, is there, do we need to have some closure in terms of the issues that they raised with the board? I mean, personally, I think that would be important just to round that off. And if they were wanting that, then I think that should be considered.
I think we've been there and done all that. I think that we've concluded that at the table engagement, and it's now referred back to the CE to engage, and we've got the report there of the 9th of February meeting, and there's actions accordingly. I have no appetite to have that engagement back at the board table. I think we've done all that. We just go back in the sequence like we do for everybody else.
So that does continue then, engagement at that level in terms of what's on our work program.
Yeah.
Okay, thank you.
Okay, rightio. So we've got just need to move receipt of the report. We've got to move in a second. So Oriana's moving receipt. Did I see your hand?
Yes, you can now.
I just need somebody. John seconding. In favour, please say aye. And against, it's carried. We're moving to the nursing workforce update.
Thank you, Brendan. Thank you, Chair.
Welcome, Selena.
I will take the paper as read. The core data set, as you can see, remains quite challenging, with staff sickness remaining high, as you have all heard. From the core data set, you can see that the acuity remains high, incidence and care rationing remain a constant, and nursing at some stages, in varying degrees across the organisation, face moral distress most days. As you can see from the report, a successful recruitment has occurred, and our newly graduated workforce, particularly our numbers of Māori and Pacifica into our NetP and NEST programs across the district. So we're very heartened by that. But note that recruitment overall saw a difficult month, with resignations outnumbering recruitments, and that was mostly due to the COVID-19 public health response vaccination order from 2021. And just finally, to highlight that our CCDM assessment has been completed by the Safer Staffing Healthy Workplace unit, and we have been informed that we have achieved full implementation. Happy to take any questions.
Fantastic, thank you, Selena. Jenny?
Yeah, so first one, I've got two questions, please. The first one, before I go on to the second one, a point of clarity. Can someone just remind me personnel cost by ward? Obviously, we have a couple of outliers there. So is that in terms of annual leave balances and that cost, or, yeah?
Sometimes it can be, but also it can be that nursing teams are undertaking more overtime and or doing extra shifts. So they're doing more than their FTE. Yeah.
Okay. And my second, I guess, statement, and I feel like possibly I've brought it up before, but it does just really continue to concern me if I look at that excessive accrued leave. And obviously, again, we have a couple of outliers there, but namely if I bring up the outlier of maternity, which of course is really concerning once again, with resignations outweighing recruitment. And I know they look like small numbers, but if we look at that in the scheme of remaining numbers as a percentage, that would be high. I imagine the excess annual leave will also then be slightly skewed in terms of the percentage, because a percentage of a lower number is likely to go up then as well. But just that direct relation that you can't, I know this COVID played a part in recent resignations too, but wasn't responsible for all of it. So I continue to just be concerned if this, what's left of this limited workforce, who clearly are expressing distress through numerous forums, if they can't take their leave either. And again, a bit like Stephen was saying earlier, it's very hard to come with a problem when you don't have a solution. And as I'm typing my notes myself, a selfish solution is, where can we bring in reinforcements from elsewhere to try and, give our team there a break? But I appreciate that there probably isn't maternity reinforcements in particular from other hospitals that we can, because I know it's a nationwide problem, but, it just, the correlation, just, we continue to just accept that high annual leave balance, but as a result, every time next month we have more resignations too, and we know that burnout of staff is part of that. So it's a very hard one to continue to watch, isn't it? I'm sure for all concerned.
It is a very challenging space, and I'm part of the National Directors of Nursing conversations, and it's right the way across the country, and there is concern. We tried really hard to ensure that nursing, that all nurses across the system could and had a summer holiday, and obviously we'll move on to the midwifery aspects that you picked up when Sarah and Jeff present their paper. But yes, it is incredibly difficult in the midwifery space at this moment in time.
Okay, thank you, Selena. I think in terms of the nursing recruitment, 20% of the new nursing recruitment were Māori or Pacific. That's a really, really impressive number.
It's starting to make some inroads here.
Really impressive. So well done. Yeah. Okay, we're all done, I think, on that report. So we need to note the nursing workforce report. Jenny, you're prepared to move? Yep, and a seconder. Thank you, Muriel. In favour, against, it's carried. We've got the midwifery workforce update.
Thank you, Brendan. Hopefully you can hear me.
We can.
Thank you. Kia ora koutou. I'll take the paper as read. There's been a deterioration in staffing that Jenny's already alluded to as expected since the previous reporting period, including 2 midwives having commenced leave without pay, 2 midwives on ACC. 1 senior midwife has moved to an LMC role. 2 midwives have reduced their FTE by 0.2 FTE, and even a minor reduction actually has an impact, like Jenny's also mentioned. In addition, 1 midwife has moved to an equity-based midwifery specialist role, Kaiara Ara Tuora. The vacancy level has increased to 11.3 FTE, excluding CCDM. However, on a positive note, 1 additional midwife commenced in January, along with 3 new graduates who will remain supernumerary until the end of April, beginning of May 2022. The new clinical coaches commenced and will support the new graduates and the return to practice midwives. And we've actually already had some interest from midwives elsewhere in the country who are graduating this year and interested in coming to work for us, which is exciting. It's also exciting to note that the midwife we've recruited from the UK is likely to get here in March rather than the June originally anticipated. A workforce escalation plan that we mentioned at the last meeting has now been agreed with unions, staff, and the ministry have also provided detailed feedback on the document. This will go live later this week. A permanent location for the antenatal clinic has been found and a lease signed for the premises underneath the birthing centre, known as the Salt Rooms. Despite all of these challenges, the maternity unit has achieved an 89.7% exclusive breastfeeding rate at the end of December, which is really to be commended. Also, finally, to note the annual leave that Jenny mentioned. This does remain a risk for us, and we're working really hard to make sure that people have adequate annual leave. We do acknowledge that it's really, really important for people's health and well-being that they get adequate leave, and we talk to leaders about that, and we try as much as possible to roster as much leave in as we can for that service. Thank you. We're happy to take any questions.
Brilliant. Thanks for the update, Sarah. Vaughan?
Thank you, Brendan. Sarah, just in regards to the support of nurses working in midwifery, that's still in place, and has that been able to be increased at all with the increasing vacancies in midwifery?
Hi Vaughan, thanks very much for that question. Yes, so we've got a clinical specialty nurse in that space at the moment that's supporting the nurses, and also we have our Associate Director of Nursing role. Our Associate Director of Nursing has actually left, and we've just recruited a new person who will start on Monday, and that person is called Josh. So he will start and he'll be supporting that space, and we have an intention, whilst that specialty clinical nurse was temporary, we have an intention to continue with that role until we're up to full staffing midwifery wise.
Okay, thank you.
Thank you.
Mataroa? Oh, yeah, Mataroa, and then Heather.
Kia ora, korua. Thank you very much for the report and for all the work that is going on to try and mitigate the circumstances to the best ability. So, and congratulations on the exclusive breastfeeding target. That's really, really pleasing to hear. So there are, as you say, there are some good things going on, and there are some things in the pipeline that are coming to fruition. I just really wanted to ask you if you thought that there was anything else that the board should be either paying attention to or that we could be doing to help mitigate the risk and the health and safety issues that are definitely highlighted in the information.
I think that's a really good question, Mataroa, and actually we feel, you know, the reporting to board and the robust conversations and the honest and courageous conversations have been really supportive to us as a leadership team, and it's been open and transparent with the midwifery team that we're having these conversations on a 6-weekly basis. From my perspective, there isn't anything else. Jeff, is there for you?
I think you've mentioned the breastfeeding, exclusive breastfeeding. Successes like that and the good news stories, which are there, need to also be spread. And obviously board members have contacts and networks outside of the DHB, and those can be very powerful in spreading some of the good news. And as we know, that can even just tip a high school graduate into thinking of midwifery as a career. And you only need to have small numbers tipped that way. This is a good place to work, a good place to come. Yes, good things happen. We've got an antenatal clinic, which is going to be located right, you know, alongside a primary birthing centre. You know, these are good news stories. And I would just say that the board members can have influence sort of probably beyond what they expect.
Yeah, no, that's good. I think that you're right, and that we should be sort of talking about the good news stories. I'd also just like to say that the other good news story is Josh Parks, who is Māori.
Yes.
And so, you know, that's a really good appointment. And he comes from a very long line of nurses, Josh. Yeah, you know, his grandparents, his aunties and uncle and parents, all mental health nurses. So, you know, thank you very much, and I hope that you continue to feel supported by us.
Thanks, Mataroa.
Well done, Mataroa. Heather?
I really want to congratulate you. I know how long you have wanted to relocate the antenatal service, and I think that's very exciting. So well done. What a great opportunity. And yeah, I was so pleased to read that. It's exciting.
Thank you.
You've wanted for a long time, I know. So yeah.
And so just reinforcing that, when I read the notes, the two points that I highlighted, the lease agreement and the 89.7%, you too highlighted that in your summary. So clearly fantastic results there. And the only other acknowledgement, well, it's not only, that's the wrong word. The other acknowledgement is that you as senior leaders are putting in phenomenal hours on the floor, providing the support necessary. And that's extraordinary. It's unreasonable, but the sort of people that you are, you do it, and you're to be admired. And thank you.
Thank you very much.
Thank you.
Can we move then to receiving the to note the midwifery workforce and the action plan? So moved by Heather, seconded by Oriana. We'll put that aye against, it's carried. We've got the board work program. I think we can receive that as it is. Oh, hold on, there's some hands up. Karen and Heather.
Thanks, Brendan. Just a quick, on page 5 under our partnership arrangements, we've had the Clinical and Consumer Council engagement today, which has been really valuable. And then there is one scheduled for March with a professional working group, but then it seems to drop off and we've got nothing in there for May and June. And I just think it's been a really valuable part of board's engagement that I wouldn't want to see drop off. I mean, I realise we've got a limited time span in terms of our existence, but I think that engagement would be good to we've dropped the ball in that before, and I think I'd like to see that we ensure that continues in that May and June meeting also with the professional groups.
I might just check in with Kath on that. There'll be some transition-y stuff as well, I presume, by then.
Yeah, I think this is the actual normal and agreed board work program. It hasn't changed.
Right.
The only thing I'd highlight in this conversation that's giving me some butterflies is we're about to go into at least 8 weeks of Omicron.
Yeah.
We are going to be under so much pressure that I just cannot even see that the next board meeting will even deliver potentially the entire program of work. I just don't know that the team or myself will be able to continue. So I guess I'll just make a plea to the board that we may need to actually not even go there next time. You know, it may be that we have a very abbreviated board meeting. We may not even have a board meeting. I guess that's up to the board. But I think we'll be struggling with what we're expecting in front of us to even get there. I mean, the team, myself, I imagine I'll be out there with my team doing everything we can to support people on the front line, whether that's delivering meals, making beds, cleaning toilets. It is going to be that grim.
Okay, let's just park that for the moment, and that's been noted, the observation, and we'll just see where we see where we land. Okay, so we've got the paper there to note the annual plan at the moment, and so moved by Muriel and seconded by John. So I put that in favour, aye, and against, it's carried. Okay, rightio. I think we're done. We just need a resolution to go into public excluded for the appropriate reasons. So we've got a mover for that. Jenny's moving and seconded by Vaughan. I'll put that in favour, aye. Against, it's carried. Look, we need to take a break, so just bear with me. Can we have 10 minutes? Come back at 11:30. Yep. So we check out. We go out of this and we come back in on a new Zoom, and everybody should have those numbers. Okay.
Did you
right,
say
guys?
11:30?
Come back. We'll come back on at 11:30 for part 2. Right.